Okay, let's talk about coronary artery disease. And the key here to remember is that the heart is full of blood. You have the ventricle and the atria that are holding lots of blood. But the problem is that that Teflon layer, the endocardium, isn't allowing the nutrients to get into the myocardium, the actual heart tissue that's doing the contraction for 24 hours a day. So here's how it has to work. Blood goes into the left ventricle, the heart contracts, it pushes the blood out into the aorta. As it's pushing into the aorta, the heart will relax. Well, now the blood wants to go back into the heart. Why can't the blood go back into the heart? Because the valve shuts. So as the blood's pushing backwards, it's starting to push that blood down through these coronary arteries. The coronary arteries come all the way along the surface, along the epicardium of the heart, and then it penetrates deep down in, like roots of a tree, down into the myocardium to nurture the myocardium. So at what phase, systole or diastole, does the heart muscle actually get nourishment? Diastole. Heart pumps out. As the heart's relaxing, the blood flows backwards and down into these blood vessels. So if your heart is sustaining contraction for a long time, what's happening to its nourishment? So if it's not getting a good diastole and it's beating really fast and never completely relaxing, what's happening to the blood flow to the heart? It's decreasing. It's starving your heart. It's going to make your heart suffer. So let's talk about what happens with coronary artery diseases. That's the next step along our pathway. Okay, so coronary artery disease is anything that narrows or occludes the arteries. So it could be, primarily it's going to be atherosclerosis. We've talked about this before. But the atherosclerosis should build up these plaques, decreasing the size of the lumen, which means you decrease the flow. A lot of times this is happening, by the time you're 5 years old, you already have some plaques that are accumulating in your arteries. And the problem is once it gets 60% occluded, so once this goes from 100% all the way down to 60% occlusion, so you only have 40% flow left in here, that's when you start seeing signs. And typically those signs come out when you start exerting yourself. You go outside in the wintertime and you start shoveling snow. Well, as you're shoveling the snow, your heart demands more blood flow. You can't open these up anymore because there's so much plaque in here, it doesn't get more open. You start feeling that chest pain, that discomfort in your chest. What do? You go inside, you have a seat, and you relax for 15 minutes. You feel better, so you think it's all over. You go back outside. Well, it wasn't all over. You just got enough flow to get rid of the pain, but you still had low blood flow and your heart's still suffering. So they go back outside, they start shoveling again, they have a massive heart attack, right? So that's an example of how atherosclerosis causes a problem. It could also be myogenic, which means the smooth muscle around here could have a problem or a flaw. It could become spastic. If it starts squeezing and contracting, it can have the same problem. You can have a 60 or 70% occlusion because of spasms, and they pinch off the blood flow. Right? So we'll talk about that too. When you look at the risk factors, they're the same risk factors we talk about over and over again. Too many fats, so too many lipids, cholesterol, triglycerides in your blood that stick to the walls and increase the risk of atherosclerosis. Hypertension, which erodes the walls or damages the walls because of all that pressure, leaving them susceptible to building thrombi and embolisms. Smoking, all the toxins in the cigarette smoke that cause vasoconstriction. So problem after problem after problem that we've already talked about. And then in the Huether McCance textbook, it talks about these non-traditional risk factors. But if you notice the theme, the non-traditional risk factors all revolve around inflammation and repair. So we talked about the C-reactive protein I had you do as a homework back a few chapters ago. The C-reactive protein is actually a protein that appears in higher amounts when there's swelling somewhere in your body. So if the inflammation is anywhere along the blood vessels, you're going to have high levels of C-reactive protein in there. Same thing with homocysteine. So homocysteine is an amino acid, but it comes out to play when there's a lot of repair going on. So homocysteine helps you build and repair tissues. If you're trying to repair these damaged blood vessels, homocysteine is going to be high in the blood. Hyperhomocysteinemia, right? It's telling you it's too high homocysteine in the blood. So these are non-traditional risk factors that we look at and we say, oh my gosh, all these high levels, you're at higher risk of heart attack. Does it mean that it's definitely the heart tissue or the blood vessels that are inflamed? Not necessarily. It could be the other tissues. You could have severe muscle damage, like you smashed your leg, and you'd have higher levels of these things in your blood too. But these are risk factors for somebody that's otherwise healthy to have these high. We start worrying about them. Okay, so let's talk about that myocardial ischemia. Ischemia is just referring to a decreased blood flow. So you have a lower blood flow. Now you have this atherosclerosis. You may have some spasms. You may have thickening of the smooth muscle around the coronary arteries, but the blood flow is decreased. Here are acute coronary syndromes. Most of these syndromes have the same symptoms. They have shortness of breath, feel lightheaded and dizzy, nausea, sweating, and often they have pain. And that pain can go up into the jaw, across the back, down the left arm. But I put stars by the pain because most of these have pain involved. But that first one, transient ischemia, may never even show pain. Transient ischemia, so you've got this roughly 60% occlusion. And then you get up in the morning and you start getting up and walking around. And when you stand up, your adrenaline levels start going up because, we talked about orthostatic hypotension. So the adrenaline starts going around. Well, the adrenaline starts constricting blood vessels. Your blood vessels kind of squeeze a little bit, and that 60% occlusion now goes to 65% occlusion. Your heart's actually suffering. It's struggling, but you don't feel pain. You might feel like sometimes like it skips a beat, or you might feel a little short of breath, but you don't feel the pain associated with it. That's transient. If we put you on an ECG first thing in the morning, we'll actually see a change in your ECG with transient ischemia, even though you didn't feel it. It's kind of a silent killer. It's one of the reasons they call heart attacks silent killers, because you can have these problems without even knowing you had a heart problem. All right? So unstable angina, actually we're going to talk about these in the upcoming slide, but sustained ischemia means that, so this transient comes and goes. Let's say that you have this roughly 60% occlusion, and then you have a little tiny blood clot that comes along, just a real tiny one, and it bumps you to 65%. Well, you start feeling this discomfort. You might feel a little lightheaded, a little dizzy, and you sit down, and then that little blood clot moved along downstream and goes or got broken apart. It's transient. You wake up in the morning, a little boost of adrenaline squeezes, you feel lightheaded, dizzy. It's transient. It comes and goes. The sustained ischemia is when it's always there. And sustained ischemia is basically turning off blood flows to the cells, and you get some of these cells that kind of hibernate, and I'll talk about that in just a little bit too. Right? So they don't really want to work as the way they used to. And then if you watch the progression, usually it goes from transient to unstable to sustained, and then suddenly you have this massive heart attack, myocardial infarction. Let's say a thrombus comes along and it sticks in there, completely blocks the blood flow down the coronary artery. That's an infarction, a blockage. If you have a cerebral infarction, it's the same thing, but it's where? It's in the brain. What do we call that? We call it a stroke, right? So you have this myocardial infarction, that tissue dies, and then you have inflammation because of the damaged tissue, you have necrosis because of the damaged tissue, and then hopefully you have repair with scar tissue. Because if it doesn't repair with scar tissue, the only alternative is that you die. Okay, so myocardial ischemia, I kind of talked about. This can be temporary, it can be sustained, but what's happening is you're blocking the blood flow, whether it's because of atherosclerosis, or it's because the blood vessel wall is thickened, or it's spasming. Any way that you're decreasing blood flow to the tissue suffers. So a lot of times what you'll see is this area here that's suffering and not getting enough flow, and it changes the electrical direction of the heart. In physiology, I know no matter who you took it with, you got hooked up to an ECG, or you hooked people up to an ECG, and you looked at something called the mean electrical axis, which is talking about the average direction of the electrical flow through the heart. Normally it's coming up here at an angle at about 35 degrees, roughly. But when you have damage to this part of the heart, it actually changes its directions. It will start shifting its direction. And so even though they may not have symptoms, you might see a change in this direction. It might give you a sign that there's something going on with the heart. All right. Angina could be a possible symptom. Angina is talking about the chest pain. There are three types that I really want you to get familiar with, and one's called stable. This is classic. This is the old traditional angina that you hear about. Somebody goes outside and they start shoveling snow, and then they get that chest pain. They have a seat. They go back outside. They start shoveling snow again. They get the same chest pain. That's stable. They also call it exertional, and I think you can figure out why. They get this pain when they exert themselves. You put somebody on a stress through a stress test, throw them on a treadmill, and they start getting chest pain. You let them off, go ahead and relax, it goes away. You throw them on the treadmill again, they get the same chest pain. It's reliable, it's dependable, it's stable. You know exactly when it's going to hit. You predict when it's going to hit. It's a big sign that you've got plenty of blockage there, and you're about to have a massive heart attack. Because all it takes is a little bit of a clot to block that up, and you're done. All right, next is unstable. Unstable is also considered pre-infarct. Unstable doesn't have to happen just with exertion. It can happen when you're sitting and eating dinner. It can happen in the middle of the night when you're sleeping. It can happen all the time. Unstable is when you've got this occlusion and things like, let's say a thrombus builds. You have a thrombus that's accumulating here. Let's say that thrombus starts breaking free, and it acts more like a valve now, right? So it's a little bit loose here, and every time your heart pumps, boom, it blocks that off. Well, the blood flow can't get down to the heart. You could be sitting at the dinner table, like I said, and then that thing starts breaking free, and suddenly you have a heart attack right at the dinner table. Okay? It's unstable. It's kind of, it's like exertional, but it can also happen other times, because these people, if the blockage is that bad already, and they go out and shovel snow, they're going to have chest pain. But then they go in to eat dinner that night, they have more chest pain. So it's kind of unstable compared to the reliable version. And this last one's really interesting, Prinzmetal. So Prinzmetal angina, this is when you hear about younger people, like people in their 20s or even teenagers that have a massive heart attack and die. What could be happening is you have this clean artery, not a lot of plaque built up. They didn't know there was a problem. And then what happens is suddenly there's spasm or constriction of the smooth muscle on their coronary arteries, which clamps down the blood flow, and they get no blood to the heart. Totally unpredictable, totally unexpected usually, because you hear about it in younger people that have this. So a lot of times it's genetic or congenital problems that are happening with the heart, and that this design is just not there. I remember when I was in high school, there was a guy that was on the baseball team, so he's like 17 or 18 years old, and he was fine, and then the next day he had a heart attack and died. I mean, he was a young guy, he was an athlete, but he had this problem with his heart, and he had vasospasms and blocked off the blood flow in his sleep, and he died in his sleep. Okay, so let's talk more about that infarction. So we've talked about decreased blood flow, we've talked about angina. Well, let's say you have the decreased blood flow, and then you have that thrombus or that embolism that comes along and blocks. Infarct is referring to a blockage. Okay. So once you have this, it's sustained ischemia, basically. So ischemia is decreased blood flow, but this is completely blocking it, and it's sustained. So there's no blood getting down to the tissues. And actually what I'm going to do is I'm just going to go to the next slide. But here's kind of the progression of what happens. You have cell injury, the cell tissue dies, you have repair or death. So one of the two things are going to happen to you. When you repair the contractile muscle, but you can also cause damage to the electrical pathway, and we'll talk about that in the next slide. And then you go from there. So here's an example. Step number 1, you have that thick myocardial ischemia, the atherosclerosis that's not letting the flow go through. Then suddenly you get a little thrombus that breaks free and boop, plugs that hole. Well, now let's say the hole plugs here. Everything downstream is called collateral circulation. All of this tissue is now becoming ischemic. Now it's becoming hypoxic. Now it's dying, right? So you're going to feel massive chest pain in this situation. Look at all that tissue that's dying, sending out its reactive oxygen species. Because if you remember, the mitochondria aren't getting oxygen. They're not making ATP. They're misfiring, making reactive oxygen species, which irritates all the tissue here, irritates the neurons, sends that massive pain up to your brain. And because the termitome lies in the same area as the left arm and the back and the jaw, it feels like the pain is everywhere, right? And that's collateral circulation. Or you could have this little blockage down here and just this little collateral area, it gets blocked off and dies. You may still have the chest pain here. It may not be as severe as this, but it's still chest pain. So number 3, I kind of jumped the gun and started talking about this, but you can see different parts of chest pain and where they can go to. So it can go down the arm, it can be right at the heart, so it can feel like you just have heartburn. Radiating down the arm, it can go across the back, lots of different places, all in the same dermatome. Right? After that, we get to the hospital. We hook you up to an ECG. One of the key signs, whether you're still feeling the pain or not, if you had a real heart attack, they look at your EKG and it has what's called an elevated ST segment. So the ST goes up. Sometimes it can be really high, so it can go up here and go down. So if it's a big heart attack, that's what you see. So for even hours after the heart attack feeling is gone, you still have this elevated ST. For days later, depending on the intensity, sometimes what you get is an inverted T. So this T wave back here, remember this is the T, can flip upside down like a U. So those could be signs that you had a heart attack. Right. Fifth thing that happens, this is kind of going on inside of your body, but we can take blood tests to look at this. But this tissue has died, right? So it's kind of popping, it's releasing its potassium, it's releasing its creatinine. So it's releasing those inflammatory factors, C-reactive proteins. So your inflammatory response starts trying to clean this stuff up, and they're putting these into the blood to circulate and get rid of. So if we take a blood test, you're going to see high levels of these tissue factors that should normally be inside the cell or out there. And then these blood cells are going to come in, white blood cells are going to come in, they're going to repair the tissue, and you're either going to get, well, a scar, or you could actually have ruptures or breakage or even worse problems that could happen. So let's look at some of those pictures of damage. Here you can see there's, come on mouse, there you can see some scar tissue that's building up here. Here you can see some scar tissue here. There you see some white scar tissue. There's some more scar tissue. Here you can see it's a little bit more mild looking. So a little fresher, I guess, is the way to look at it. But scar tissue. So let's see if you remember what this is. This is actually necrotic tissue and scar tissue. So the necrosis is because of proteins. You're talking about muscle, high levels of proteins that are clumping and sticking together. What kind of necrosis is that? Clumping and sticking together. It's coagulating. It's coagulative necrosis. Right? So here's kind of the pathway, and you can follow the different slides we just went through. You get that atherosclerotic plaque, right? It slows the blood flow. When you slow the blood flow to over 60%, you have this stable angina, right? Because it's a stable plaque. It's dependable. It's not moving. It's not changing its shape right away, but it's decreased your blood flow. You get on a treadmill, you start feeling that pain. Right? You get off the treadmill, the pain starts going away. It's stable. Well, what could happen is if you get a slight rupture to that stable plaque, you can start accumulating that clot. Remember that thrombus? So let's say that thrombus starts acting like a valve. It's a stable plaque, but now it's got that valve-like piece of clot going back and forth. So now it's unstable because you could have exertion and you get that pain, but then at the dinner table, suddenly you have this chest pain too. It's unstable. Next, you can have that transient ischemia. It comes and go. Or sustained. Let's say that thrombus just keeps getting bigger and bigger. It's staying very firm. It's staying right there along the plaque, but it gets bigger. That sustained ischemia is causing the heart cells to not want to fire. They're deprived of oxygen. They don't want to work. And there are two special types of cells that these become. So, well, three, I guess. One's called dead. So one is the cells can completely die. They can become replaced by scar tissue. Or they can stay alive but not functioning appropriately. So let's say you get that blockage. Within 5 to 15 minutes, if you don't replace the oxygen, you actually get these things called stunned myocytes. These stunned myocytes, they can actually be salvaged, but they shut off. They basically stop working until they get reperfusion, until they get new fresh blood flow. So what you see with this is you see like this prolonged post-ischemic problem because they were deprived and now they're going through reperfusion injury. They could either die or they can kind of limp their way back into activity. The other is a hibernating myocyte. Hibernating is pretty much like a stunned myocyte, except the hibernating, because of this damage, this chronic damage, it will never contract the same. So it just slowly decreases its function, but never comes back. It doesn't matter if you put plenty of oxygen into the person's system. That's never coming back. It always stays basically in a limp state. It's alive, but it's barely contracting. Right? So those are two major types of remodeling that can happen to the actual heart cells. Another remodeling could happen to the autorhythmic cells, not the contractile heart cells, but the autorhythmic. If the autorhythmic cells are damaged, then your electrical firing is going to change, which brings us to the next part. So remodeling, oops, I guess it doesn't. I forgot this part. So here are some of the heart, when you have the contractile tissue remodeling, some of the three major problems that can happen. One is you can have dilated cardiomyopathy. And what happens is that this tissue, it doesn't contract. It expands and it stays stretched out. So more blood goes into the left ventricle, but the problem is it doesn't leave. It can't contract, so it doesn't leave the left ventricle. So you get a little bit of squeezing here, a little squeezing here, and you're pumping a little bit of blood out, but a lot of that's sitting in there. It's just swishing around. What's the problem that could happen here? Yeah, you could have coagulation. You could have a thrombus forming on the wall there. You could have clots that are forming right mid-bloodstream, and then they travel downstream and cause problems. So that's dilated cardiomyopathy. They also call that congestive cardiomyopathy because that area is congested. It's all backed up. Just like when you're congested, in your nose, you have snot accumulating here. Here, the heart has accumulating blood. All right, the next one is hypertrophic cardiomyopathy. Typically, this happens when you have a stenotic valve that doesn't open completely because the heart has to work harder to push the blood out. Or if you have really hardened arteries and hypertension, the heart has to work harder to pump that blood out. So the wall of the heart gets thicker, the actual wall. Well, when the wall gets thicker, the easiest way for it to expand into is inside. So look at the volume. Here's a normal volume in the left ventricle. You have very little volume there. You have a very strong heart, but you're not actually pumping that blood very efficiently. So both of these have similar problems. You're not pumping enough blood. And the last one, restrictive. So restrictive, let's say you have scar tissue that's accumulating here. It's not letting it expand, but that scar tissue also doesn't contract, so it can't squeeze in. So you can see the volume here is pretty close. The problem is that you can't contract this. It's restricted and it can't squeeze. Alright, so dysrhythmias are another possible outcome. You affect that autorhythmic pattern, those autorhythmic cells, the electrically active cells, and you can see changes on ECG. And we call those dysrhythmias or arrhythmias, and it's just any disturbance of heart rhythm, the electrical patterns that are going on. You can have a missed beat, you can have extra beats, okay? You can have all kinds of problems in between. And you can see the primary causes down here. We've already talked about coronary artery disease. It ends up remodeling the heart. Okay? Or you're depriving blood flow to those electrical activity cells, the autorhythmic cells, and they don't want to fire. Or, we talked about this the second week, you can have sodium, potassium, calcium, chloride. Those imbalances in electrolytes can cause problems with the heart. The heart depends, actually I'm going to go to the next slide and show you. The heart depends on things like sodium, calcium, potassium. This is a contractile cell, remember? Sodium races in, depolarizing the cell. It starts repolarizing with a little potassium, which is number 3. But that calcium creates a sustained plateau for a good firm contraction. And then the potassium repolarizes. So you've got these 3 major elements that are going on here trying to keep the heart contracting. If you throw any of these off, you can see arrhythmias. Like when you try and kill somebody, they give them potassium chloride. They're affecting the potassium in their blood, and it's making their heart stop. Right? So electrical disturbances can be caused by electrolytes. Right? Changes in the heart muscle I already talked about, injury from prior damage, or even infections or surgery can do it too. All right, so let's remember what the electrical pattern is. It starts at the SA node. The SA node fires and it sends an electrical activity all the way across the top of these contractile cells in the heart. When you're looking at an EKG, this is important to remember. It's typically not the autorhythmic cells you're actually seeing affect ECG patterns. It's the electricity traveling across contractile cells. So as that electricity shoots across the top of the contractile cells, all those contractile cells across the atrium, you see this little bump, the P wave. Boop! And there it is. It's not a lot of electrical activity, but that electrical activity allows that stimuli to travel, and then you've got this kind of a pause electrically. So here, I'm going to go up to this one. Here you have the P wave. The atrial contractile cells are depolarizing. They're getting the electricity. Well, then they have that sustained contraction. They're contracting, contracting, contracting. But this is an electrical scale, not a mechanical scale. Contraction is mechanical. You can't see the contraction on here. You just have to imagine. Electrical firing, zap. Contract, contract, contract. Right? It's squeezing the blood out of the atria. Well, the whole time that's contracting, that electricity is sitting here at the AV node. It's not moving, so you can't see the movement on an ECG. It's just sitting there. Then suddenly, sends it down the bundle of His, down the bundle branches to the Purkinje fibers, and up and into the myocardium of the ventricle. As it's shooting up into the myocardium of the ventricle, all those contractile cells are being electrically activated, and you're seeing this huge spike in the R. So the QRS is ventricular contractile cells depolarizing. So the P wave, or atrial depolarization, the P to R segment, this flat line kind of here, is that the electricity is not moving. It's sitting in the AV node. The QRS is the ventricles are depolarizing, and now this is just depolarization, the electrical activity. During this time, now you would see the contraction of the ventricles. They're squeezing, 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 but that's mechanical. You can't see it on an electrocardiogram. It's electrical. So they're squeezing, squeezing, squeezing. But then now they're going to repolarize right here. So electrical activity fires in them, sustain, 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 squeeze, 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 and now repolarization. That repolarization is the T wave. So you see another electrical bump, another electrical change in activity. So that's your P, your QRS, and the T waves. And then you have a sustained flat line between the T going back to the next P, and they call that TP segment. That's when the heart electrically is at rest. Right? So the ventricles are relaxing, they're sucking blood back in, but they're not electrically moving. So if you don't remember this, open up your physiology book and go back and refresh yourself on it. So you can see with a normal heart rate, here you can look, beep, 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 beep. If you look, they're all about a second apart, roughly a second apart. If they're a second apart, how many beats per minute is that? 60. That's a regular heartbeat, right, or heart rate. So that's normal rhythm. If you look at some of the abnormal rhythms, you can have a fast heart rate, which is faster than that 1 beat per second, and technically that's called tachycardia, which was over 100 beats per second. You can have a slow heart rate that's spread out between the R's, that's bradycardia. You can have irregular rhythms, so you can have a heartbeat, heartbeat, skipped a beat, heartbeat, 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 heartbeat. So irregular rhythms. You can miss a beat altogether. And those are dysrhythmias. And a lot of these you can look up in the book, and a lot of them are kind of self-explanatory, like premature ventricular contractions. It just means that you have that normal pattern. You'll have, I don't think it's over here, but here's some samples. So you'll have, where's the normal? Well, this is fast, but it's normal. So you'll see there's the QRS, there's the T, there's the P, another QRS, T, P. But what would happen is you'd have the P, QRS, T, and then instead of another P, you'd have this really weird abnormal pattern because the P and the QRS would fire at the same time. So you get this strange pattern, right? So you've already seen tachycardia, you've seen premature ventricular contractions, flutters and fibrillations. Fibrillating, it means that the electrical activity is not in sync at all. That means the ventricles, well, typically we talk about ventricle fibrillation. The ventricles are just jiggling their electricity. They're never completely relaxing. They're never completely contracting. They're just jiggling around. So the best way to fix that is to zap the whole heart at one time with electricity and try and reset it, defibrillate it, right? Heart blocks, there are really three that you want to remember. There's a first, a second, and a third degree. Those are the three significant ones. The first degree heart block means that by the way, those three all revolve around the AV. So the AV node's not working appropriately. First degree heart block means the AV node is holding on to the electricity too long. So which of these segments would you see change? The P, the PR, the QRS, ST, or the TP? Well, the PR represented AV node delay. So if the AV node's holding on to the electricity too long, what happens to that delay? It gets longer, right? So first degree heart block, you see a longer PR segment, which represents AV node delay or abnormal AV node delay. Second degree heart blocks, the way I always remembered it is usually you'll see two P's for the QRS. So what happens is that only about 50% of the electrical activity gets through the AV node. So you get an electrical activation at the atria, it shows the AV node, and it stops there. It doesn't move on. So you see a P wave, but you see no QRS with it. And then another electrical activity at the SA node shoots across, so you see a second P wave, but this one goes through, and then you see a QRS. So I always remembered second degree, typically you see two Ps for every QRS. And it's because only about half of the electrical activity is from the atria to the ventricle. And third degree means that it's also called a complete heart block. So what's going on here is the AV node is completely blocked. It's not just a longer delay. It's not that 50% get through. It's that none of the electrical activity gets through. So the SA node will fire the atria, but the ventricle don't just stop because they have their own autorhythmic cells. They have the Purkinje fibers. So the Purkinje fibers that fire slower than the SA node will fire at their own rate. So you may see the atria firing, so you'd see a P wave, P wave, P wave, P wave, but then you'd also see a QRS, but it'd be more spread apart. QRS, 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 because the QRSs are slower than the Ps. So a lot of times you'll actually see three Ps in between two QRSs. That always helped me remember third degree block. But third degree block, their AV node in the heart is completely stopped. It's not working at all. So the atria and the ventricle are working at two completely different rhythms. Right? And then cardiac arrest means complete electrical stop. Right? So sudden cessation of electrical rhythms. They stop breathing. They stop basically doing anything. Their heart stops. They've got about 15 seconds before they're unconscious, right? Because you remember that from the brain. If the brain's deprived of oxygen and glucose within 15 seconds, that person's unconscious. Within 5 minutes, they start having irreversible brain damage. So is this a bad thing? Hell's yeah, it's a bad thing. This is why they created defibrillators, right? So that if somebody has fibrillation or they have cardiac arrest, you can zap them or shock them back into rhythm. The problem is with cardiac arrest, there's usually some kind of a cause. Like it could be they had drugs in their system that made their heart stop, which is going to make it hard to keep it going even if you restart it. It may have just been that they were deprived of, I'm trying to think of a really good excuse, deprived of oxygen would cause the myocardial infarction. They see the signs. So they were already shocked by something else. Let's say they touched their hand across both battery posts and they shocked their heart into stop. If they were working on electrical lines in their house and they grabbed the electrical lines inappropriately and the electricity stopped their heart. So there's usually something that triggers this. Usually the heart just doesn't stop on its own like that. There's something that causes it or triggers it outside. So cardiac arrest, you don't see symptoms as yourself. You see symptoms as an observer because they just pass out. They just suddenly collapse. They have no pulse. There's no breathing. They're not there. If you were to hook them up to an ECG, there's nothing. They're flatlining. So that's a sudden cardiac arrest. Very different than a heart attack, because a heart attack is because of the blood flow or the plumbing, right? So here's the electrical, here's the actual plumbing. They're not getting blood flow. They can feel the pain. They're awake, right? Because what's happening is their heart's still beating, but it's beating in a weird way. They're feeling the chest pain because part of the heart is dying. So they're still pumping some blood to the brain, keeping them conscious. There's a big difference between a heart attack and a cardiac arrest. Right? So if you take all those things we talked about and kind of put them together, you can see how some things can be a symptom. Ischemia can be a symptom of something like atherosclerosis. Ischemia can be a symptom of not beating the heart hard enough. Like the left ventricle not pumping blood, you're not going to get it into the coronary arteries and you have problems. It could be electrical instability. Any of these can cause problems to each other. So it can become a circle pattern instead of just this pattern that I showed you before. Right? So any of them can cause problems with the others. Okay, so let's move on to heart failure, kind of moving into the end stage here. So heart failure, a lot of times we call it congestive heart failure, and it actually describes a lot of types of cardiac dysfunction that are not giving adequate perfusion. So you can have left heart congestive heart failure, which doesn't pump to the system efficiently. Usually you see like the brain not getting enough circulation, all of the organs not getting enough circulation, including the skin, so they turn pale, right? They may turn a little bit blue. They may feel like they're trying to breathe because they're not getting oxygen moving efficiently. So left congestive heart failure is not pumping to the system efficiently. It could be because the walls don't stretch appropriately and it can't hold the blood. It can be because they're overstretched and they can't contract appropriately. It can be any of these problems. Right? So when you think about what's going on, if your heart's not pumping blood efficiently, what's the hypothalamus going to think of that? What's the medulla oblongata going to think of that? So what's going to happen to your blood pressure? Well, it's going to drop. What's the medulla going to think? Turn up the sympathetic nervous system. Right. So the sympathetic nervous system comes up and it starts constricting blood vessels and trying to make the heart beat faster. The heart's already broken. It's not going to beat faster. The blood vessels are going to constrict, but they're actually going to decrease blood flow to other organs. So you've got this circular effect where it's one thing causing the original thing, which causes more of the symptoms. So heart failure is usually referred to as an end-stage type of situation where it's hard to come back from this. What would the kidney start doing if you're not moving blood and you're not getting good blood pressure? Well, the kidney's going to release renin, right? Renin's going to make you retain sodium in the long run. Sodium's going to make you retain water, increasing your blood volume, increasing your blood pressure, but are you actually moving the blood? No. So you're still not moving it. It's a dangerous cycle where everything starts shutting down. Right? Typical causes: coronary artery dysfunction, damage to the heart wall, the heart having scar tissue and not being able to contract appropriately. Basically all the things we've talked about before. Anything that revolves around the heart becoming a poor pump is what you want to think about. So if it's left congestive heart failure and the right's working okay, right's pumping blood to the lungs, but unfortunately the left's not pumping it to the system. Where's the blood going to back up at? If it's left congestive heart failure, the blood pumps into the lungs, but it doesn't leave the lungs efficiently. Blood starts pooling in the lungs. That blood starts diffusing its liquids over into the alveoli. What's the problem here? You're getting pulmonary edema, right? So left congestive heart failure usually is pulmonary edema. You start seeing a lot of breathing problems. You might hear the crackles in their lungs from the fluid accumulating. If it's the right side's not pumping into the lungs. So the lungs aren't getting enough blood. Where's that blood pooling? The blood's pooling in the system. It's backing up in their system. These people, you see edema, but not pulmonary edema. Where do you see it? Systemically. When they're on their feet all day at work, they get home from work, their legs are swollen huge because of all that fluid that's backed up in their system. You know, they have a higher chance of varicose veins. They have higher chance of having venous stasis ulcers. They look like they have bruises around their ankles. They're working all day and all that blood's pooling at their feet because their heart can't move it efficiently. They're not picking up adequate oxygen. They always feel like they're winded. They're not getting enough air. Right? When they lay down flat at night and they get up the next morning, suddenly that edema around their feet is gone. Did the edema go away? No. With right congestive heart failure, the edema is always there systemically. It's just distributed across their body when they're waking up in the morning, and then after being on their feet for several hours, it just pools back at their feet again. So a lot of times you see physical symptoms like blood backing up into the arms, the legs, the ankles, the feet. It can back up into the liver, the lungs, other organs. It can go all over the place. This is called congestive heart failure. Everything's starting to pool and backing up. So, I kind of already did this on the last slide, but left versus right heart failure. And with left heart failure, remember, you're not pumping adequately to the system. With right heart failure, you're not pumping adequately to the lungs. Right heart failure is also called cor pulmonale. And then you can actually go back to that flow chart. I walked through it with you. I just didn't walk through it with you on this slide. All right, and then the last question for this section, homework number 4. So the diagram of the heart over to the side there shows some problems that happen congenitally. So you can have lots of these congenital heart problems. And it's actually pretty common. It's usually about 1 per every 1,000 live births. So some of them are hidden for a long time. People don't know it until adulthood. Something happens and then they start showing. Some people live a whole long healthy life with some kind of a congenital defect or a change to their heart. But there are a lot of different things. It can be heart valve defects, narrowing, stenosis of the valves. It can be defects to the walls, where the walls don't want to contract completely, or the septum doesn't form completely. Or, well, I almost gave away one of these answers, but it can have all kinds of abnormalities to any of those structures. The heart is a very precision machine. I feel like I'm selling you a BMW, but it's a precision machine. All the pieces have to be working appropriately, and if they're not, you're going to have some kind of a problem. These people may not know they have a heart problem, but they may be sucky athletes. They just feel like, God, every time I try to run, I feel winded all the time. I can't do it. I'm not a runner, is what they say. But they didn't know they had a heart problem. So your job is you're going to look up some of these more common ones. So what is a congenital heart disease, or describe to me congenital heart diseases that happen to the aorta? Give me an example of a common one or the problem that can happen with pulmonary artery. What is patent ductus arteriosus? And then what kind of disorders or deformities happen to the septum? What could be the problem? So you can look at your textbook, you can Google them online, you can flip through. You can see when you flip through your textbook to the childhood heart issues, they're basically the adult heart issues, but just applying to kids. So they have a little different names, and a lot of times they're born with the defect instead of causing it by eating too many Big Macs. So I love this. This must be Iowa, right? So there's Interstate 80 with the green lines going across. And there's that road going up to Minnesota, which I've never taken in my life because I hear Minnesota's a scary place, right? Anyway, so here you can see there's the bad route. Here are all your risk factors that can lead to things like heart disease, coronary artery disease, coronary vascular disease, coronary heart disease, which, by the way, all 3 of those are the same thing, and the premature death. Or here are the good road. Living your life appropriately, not smoking, eating the right foods, having a normal weight, keeping your blood pressure under control, avoiding diabetes, type 2 diabetes. So there's your long, healthy life.